Hello and welcome. My name is Professor Russell Lewis. On behalf of my colleague, Professor Methi Chayakuri, I'd like to welcome you to today's webinar, Antifungal Stewardship in the Times of Complicated Medical Decisions. This webinar is part of the SHAPE Antifungal webinar series of 2021, The New Normal, Optimizing Management of Invasive Fungal Diseases During the Best Practice Approaches. If you missed the previous two webinars in this series, you can watch them on demand. Also remember to visit the SHAPE website to listen to the podcasts and to find links for joining the remaining webinars in the series. The agenda for today is we're going to have a short presentations of about 20 minutes. I'm going to set the stage for Methi to talk a little bit about the principles and challenges of antifungal stewardship in clinical practice. And then Methi is going to talk about real-world experience with antifungal stewardship in an evolving healthcare landscape. So without too much more delay, let's go ahead and get started. In talking about principles and challenges of antifungal stewardship in clinical practice, it's important that I do point out that I have done some research and work with advisory boards for some companies who deal in the antifungal space. But the objectives of this session, what I'd like to do is provide you with a little bit of a background of why I think we can make a case for antifungal stewardship. What are the differences and similarities of antimicrobial and antifungal stewardship? Then I'd like to introduce you to 7 core principles of antifungal stewardship that we recently presented or developed in a document from the Mycosis Study Group Educational Consortium. And then finally, how do antifungal stewardship practices impact treatment decisions? Because this is ultimately what we're interested in. Now, if I were to define antifungal stewardship, I'd probably define it exactly the same way I define antimicrobial stewardship. And there's definitions in the literatures, like from this one from the Infectious Disease Society of America, that say that stewardship is essentially coordinated interventions designed to improve and measure the appropriate use of antifungal agents by promoting the selection of optimal antifungal dosing regimens and drug regimens, including dosing, duration of therapy, and route of administration. So it's really the same in that respect. But where there are differences is when you start thinking about the hosts of who develops invasive fungal infections, typically more critically ill and complex patients or severely immunocompromised patients. Clinician knowledge of invasive fungal disease and antifungal drugs is usually not as universal, especially outside of infectious disease, the ICU critical care disciplines, and hematology oncology. Many times prescribers may not be as familiar with these drugs and the appropriate interpretation of microbiology results. I think the laboratory is where there's really major differences. Certainly, when we think about bacterial cultures, they tend to be high yield, they're relatively sensitive for pneumonia or obviously bloodstream infection, and they give us a lot of information that can be used to target our therapies, and we can perform susceptibility testing. And usually susceptibility testing or MIC results have good correlation with clinical outcomes. This is not necessarily the case with antifungals. The cultures are lower yield, especially for molds, and susceptibility testing may not be uniformly available at all institutions, and this is obviously a major challenge in selecting therapy. We also have fewer therapeutic options when it comes to antifungal therapy, and this is certainly, there's limitations with toxicity and drug interactions, especially when we talk about treating invasive molds. And in some cases, we may have to treat invasive molds for months, if not even years, and this is another big difference. So when you're trying to translate concepts and approaches to antimicrobial stewardship, there are some important differences when it comes to antifungals. I think, though, there's a lot of interest in antifungal stewardship, especially with increasing multi-drug resistance that's now being reported across the world. The explosion of Candida-resistant, drug-resistant Candida auris that's been seen in many continents, including the United States, where there's been a recent outbreak, for example, in Texas and Washington, D.C. area, of completely drug-resistant Candida auris that infected patients, even patients who had never received an antifungal. So the increase in these infections is a major concern, and also antifungal resistance in the environment with the widespread use of agricultural fungicides that are similar to triazoles. We're seeing triazole resistance in Aspergillus species, and this has had an impact on our empiric therapy for preventing and treating these infections. So there's a lot of reasons why I think we can make an argument for antifungal stewardship, of course. It's consistent with antimicrobial stewardship in general, but most importantly, the main thing we want to do is improve patient outcomes, and that's our overall goal. So there's lots of resources we can look to if we're talking about antifungal stewardship specifically, and two that I would recommend. One's from the British Society for Antimicrobial Chemotherapy, a very nice e-textbook or e-book that can be downloaded for free, that has a number of chapters on antimicrobial stewardship, but also a specific chapter dedicated to antifungal stewardship that makes many of these points that we're discussing today. And then, of course, there's the core elements of stewardship programs that have been proposed and published by the Centers for Disease Control in the United States. There's other similar documents in other countries, but this is a document, especially for US practitioners, that has been very important because it forms the basis of accreditation standards that are required for hospitals that must have stewardship programs. And this is the document that was of particular interest to the Mycosis Study Group Educational Consortium when we began to look at those core principles and ask, are these directly applicable to antifungals? How might they be different? Where may clinicians or need to think about applying these differently when it comes specifically to antifungal therapy? So in an initiative developed by Demetrios Kontanyanis at MD Anderson Cancer Center and John Perfect at Duke University, we got together a group of stewardship experts from across the United States and in Europe, and tried to provide a document that really dives into these issues and discuss how these 7 core elements may change specifically when it comes to antifungals. And this was published in the Journal of Infectious Diseases 2 years ago in a supplement that can be downloaded. So I highly recommend checking out this document because it's very detailed. And what I'm going to do is just provide you a little bit of an overview of what this document contains and some of my personal experience of applying it here in Bologna, Italy. There are 7 core principles of antifungal stewardship that are very similar to antibacterials. And the first one is always important. Get the administrators on board. You have to engage senior management towards stewardship. And what's been found is that one of the most common predictors of when antimicrobial stewardship programs fail is when they do not specifically have senior leadership support or resources to carry out the program, because it does take work, it does take FTEs and persons and people's time to effectively improve antifungal prescribing. And this was actually shown to be the most important component for meeting all 7 CDC core elements. So just jumping in and trying to affect prescribing or education, it's actually more important to get the institution in the same path, particularly with administrators towards stewardship programs. You also have to identify who's going to be accountable and whose job this is going to be. Usually stewardship teams have an ID physician in charge, working closely with an ID pharmacist, but it's also important to have a multidisciplinary team and outreach to the main specialties that are the most frequent prescribers, such as physicians in the ICU, hematologists, transplant physicians, for example, because these are the ones you're really going to need to communicate with and have a rapport with. Obviously, we do think it's very important that for many invasive fungal diseases, patients do have routine ID consultation. We know from the antimicrobial stewardship literature that, for example, Staph aureus bacteremia, the mortality is improved when patients are seen by an ID consultant, and this has similarly been shown for invasive fungal diseases. This is data from Barnes-Jewish Hospital in St. Louis, published in Lancet Infectious Disease a couple of years ago, that showed that patients with invasive candidiasis, Candida bloodstream infections, even if you adjusted for severity of illness and other risk factors, patients who had an ID consultation had improved survival probability compared to patients who were not seen by an ID consultant. So this is can play a very important role. I think one of the biggest challenges and one of the most important areas is diagnosis, because obviously timely diagnosis is key and essential to good outcomes with invasive fungal diseases and giving the chances for antifungal therapy to work. And having access to timely microbiology and non-culture based diagnostic testing for Candida and Aspergillus species should be a major goal. And this is where a lot of resources probably need to be directed. In the guidelines, or I shouldn't call them guidelines, really the document that the Mycosis Study Group Education Consortium developed, we tried to provide a background on the diagnostic tools, and in particular emphasize the negative predictive value of these tests, because it's often the negative predictive value that's used by clinicians and stewardship teams to try to curtail unnecessary antifungal use. And it's very important to consider these tests at what pre-test probability they're being used. So if the prevalence is 2%, you can see here that all of these tests used for invasive candidiasis, PCR, galactomannan, they all tend to have very high negative predictive values. So sure, you could test everybody that's coming into the ICU or coming into the hospital, but you're doing a lot of testing, and you could stop therapy based on this test, but it may not be the best use of the test. As you get into higher positive predictive values, the negative predictive values may drop a little, and this is where understanding the test becomes more important, and especially if you're using them at the time of diagnosis, meaning the patient has symptoms, they have very high pre-test probability of disease, 30 or 40%. This is where some tests may be very good or useful for stopping or withholding antifungal therapy, but other tests, for example, galactomannan, may have some problems. So diagnostic stewardship is absolutely integral towards antifungal stewardship, because inappropriate use of diagnostics is also a waste and expensive, and it also may drive inappropriate use of antifungal therapy. So just to give an example, the T2 Candida test, a very sensitive specific test for bloodstream candidiasis, if we were to use this test in a general ICU population, and maybe the prevalence is 2%, for every 100 patients we screen, we would only have 2 true positives and we'd have 2 false positives. So we'd have just as many false positives as true positives, and we'd be doing a lot of tests, spending a lot of money, probably not very wisely. On the other hand, so this probably wouldn't be the best way to use this test in a stewardship approach. But what if we could identify a population in the ICU who's much higher risk, 20 or 30% prevalence? Then the test, we could take advantage of the high negative predictive values. So over 100 patients screened, we would certainly help confirm the diagnosis in 27 patients, true positives. There would be a few false negatives and a false positive, but here, now we have almost 2/3 of patients could be true negatives, and this might be an opportunity for streamlining or reducing excessive antifungal use even in higher risk patient populations. Just another example for invasive mold disease, because I want to make one other point. How do you find these patients that are 30% risk? Obviously, this is the big challenge. There's been a lot of approaches that have been trying to identify these high-risk populations. One of the most common is using institutional risk scores to try to screen out lower-risk patients. And by using clinical risk scores, you might be able to improve your ability to identify the patients who would benefit most from more intensive antifungal diagnostic approaches and possibly even prophylaxis. So this is an example of a risk score from the mycosis study group by published first author was Luis Ostrowski-Zeichner. There are many others in the literature, and in general, they have a good negative predictive value. They don't have a high positive predictive value, but by applying the simple indicators, you can identify a population from the general ICU population that's at higher risk, and that's where you might consider using these more expensive diagnostic tests. I will say that risk scores generally have to be adapted to the individual center, and you always have to verify and validate them before you start using them in patient care. So just another example is, I think, where we run into challenges with diagnostic testing is galactomannan. This is a test that has a sensitivity of 71% to a specificity of 89%, even though the overall prevalence, if you were to apply this in the general ICU, general hematology unit, for example, in our hospital, in our hematology unit, the overall prevalence is 3% of invasive aspergillosis, proven or probable. So if we screened everybody that came into our hematology unit, for every 100 patients we screen, there would be 2 true positives, and we'd have 11 false positives. And this is one of the problems with galactomannan. And we would be sending more people to the CT scanner than actually needed it. And this is so that's really not a good idea. We want to identify patients where the false positives are not outnumbering the true positives. Alternatively, what if the patient had fever, nodules in their lung, they had the clinical risk factors, they were neutropenic? This would be like an EORTC possible infection, invasive aspergillosis, a 44% pretest probability of disease. Well, we could screen all these patients for galactomannan, and that's what's typically done. And certainly there's going to be true positives. There may be some false positives. There may even be some true negatives, but the problem is there's still enough false negatives that we may not be able to stop antifungal therapy if a patient has an active lesion in the lung, if they have fever and they have suspected infection. So we would need a combinations of tests with very high sensitivity and specificity to just simply stop antifungal therapy on the basis of diagnostic tests. So I'm just pointing out that these tests do take interpretation and expertise to consider when doing this. In Bologna, we do have a clinical risk score that we've developed for invasive aspergillosis, invasive mold disease, that we apply when patients come into the hospital. And using 7 clinical risk factors, this was designed from a large study of analyzed over 19 candidate risk factors over 10 years. We can predict with reasonable certainty whether a patient is at very high or very low risk for invasive mold disease using a simple tool that we actually now use on the cell phone. And one of the things that this allows you to do, for example, this is showing you different types of patients, different groups of patients with hematological malignancies. For example, acute myeloid leukemia, myelodysplastic syndrome. Overall, the prevalence of invasive aspergillosis proven or probable in our disease is 6.7%. But do you need to give antifungal prophylaxis in all admissions, 1,100 admissions? The answer is probably no. Using that simple risk score, we can identify 388 of that 1,100 admissions where the incidence was very high. And these are patients usually getting induction chemotherapy that would get, for example, posaconazole prophylaxis. But over 712 admissions, the prevalence was very low, 2.4%. These are usually patients in consolidation therapy who are in remission. And so we don't need to give prophylaxis, and we probably don't need to do aggressive galactomannan screening. Another place where I've seen this score useful is lymphoma patients, usually low risk. The prevalence is 1.5% overall in our institution. And the vast majority of patients, if we apply the score, the vast majority of admissions, the risk is very low, less than 1%. So we don't give prophylaxis, obviously. We don't routinely do galactomannan screening, but we do identify a subset of patients who are extremely high risk, 13.2% prevalence using the clinical score. And these are patients who typically are receiving steroids, they've been treated heavily, they have had an autologous transplant. And these are patients we might actually consider prophylaxis or at least careful monitoring because they are at higher risk. So these clinical risk scores can have some advantages. Something else that we have an advantage of, a tool that we have in Bologna, is a very good radiology department. We can do very timely and rapid CT scanning. And CT findings, especially in high-risk hematology patients, are often a trigger for antifungal therapy. When you have nodules in the lung like this or dense consolidation, it's very difficult in the very high-risk patient not to start antifungal therapy. But as we see in this example, in more than half the cases, the nodules or the infection is not due to a mold, it's due to bacteria. It could be due to lymphoma or even a viral infection. So by using CT pulmonary angiography, when a patient comes in with a suspected nodule and we're worried that it might be fungus, the radiologist can do a decision to perform CT pulmonary angiography, similar to what is done to detect a pulmonary embolus. And if they see interruption of the vessel, a vessel occlusion sign is seen here, then this is very suggestive of an angioinvasive process and highly specific for some type of invasive mold disease. Compare this to the infiltrate on the left. This actually was Pseudomonas. It looked like a fungal infection on the CT, but the angiography, we see patent vessels throughout the infiltrate, and we could actually rule out fungal infections. And this is a test that we use, for example, in Bologna, to try to help stop or curtail unnecessary empiric antifungal use. So this is something that just points out that there's many ways of trying to find the best diagnostic approaches to improving therapy. The other things, of course, that are important, education is always important. There have been surveys done by Spanish investigators, for example, that show that 1/3 of European prescribers do not correctly identify clinical indications for antifungal prophylaxis, and nearly 1/2 do not appropriately differentiate colonization versus infection from microbiology results. But education by itself is not enough. It's part of a more broader package of stewardship approaches. And of course, I think probably the most important of these is being on the ground. Certainly, as we mentioned earlier, consultation by ID experts is helpful. You can develop institutional care pathways and treatment bundles, but ultimately what's been shown to be most effective is having the clinicians and the stewards there on the units where the heavy prescribing occurs to discuss the cases, to provide post-prescription feedback, and do what they call handshake rounds, which basically means have personal contact. I know it's been a little bit curtailed in the COVID era, but having personal contact and building trust and a shared responsibility for caring for the patients. And that's ultimately, I think, a very important point that needs to be done. You can't just restrict the drugs. You can't just have pre-approval. You have to have personal relationships with the prescribers. There are, of course, many national and international guidelines that can be used as a basis for building treatment pathways, treatment algorithms, treatment bundles, but they really have to be adapted to your center. And one of the problems or misconceptions, I think, is that you have to do everything. And the reality is, no, you should probably pick 3 or 4 things that can be done in your institution in a very timely and logical manner, and that can have the greatest impact, and then build upon that early success and develop more comprehensive approaches and treatment bundles for managing the infections. Finally, the last couple things, certainly you need to understand if you're making progress and having some kind of local surveillance for not only the type of pathogens you're dealing with, but ideally if you're seeing resistance and if you have susceptibility testing available, looking at periodic trends and reports of the type of pathogens that are being encountered. Also, if you have therapeutic drug monitoring, looking at how frequently the concentrations fall below therapeutic levels, and trying to evaluate the quality of antifungal prescribing in your institution. And there's a lot of discussion in our MSG consortium document about the challenges of reporting and the issues of tracking antifungal use, days of therapy versus defined daily doses, and some of the challenges you might run into in analyzing this. I won't go into this now, but I think it's detailed in a lot of detail. It's provided in the document and can be very helpful if this is something that you're struggling with in your institution. So putting it all together, as I mentioned, I think there's some early wins and easy things that can be done in the beginning in any center. You can develop your own treatment pathways and bundles. You can develop your own educational programs. You can review how antifungals are being used. And certainly you can try to do as much surveillance and look at your diagnostic tests you have available, and then basically get up on the floors where antifungals are being used and discuss the patients. Beyond that, then you need things like susceptibility testing, therapeutic drug monitoring. You may need more intensive IT resources that may not be available in all centers, but can be achievable over time if you're showing benefits with your early interventions with antifungal stewardship. And then in the document, we talk a little bit about aspirational things that we think can be done that maybe are borderline research, but we think could move the field forward in terms of improving antifungal use, especially maybe in the setting of clinical trials. So this is sort of an overview of the document, and I think the rationale of why we feel antifungal stewardship is important. Obviously, it requires unique expertise and resources, but I think if I were to give a few closing recommendations, you can certainly start by looking at how antifungal prophylaxis is being used in your institution. Also, you can look at empirical therapy, although that's often the one that's most challenging to address. But look at your diagnostic algorithms, because a lot of times that's the hidden area that's driving antifungal use. And if diagnostics are being used inappropriately, it will drive inappropriate antifungal therapy. You absolutely have to engage the key prescribers and provide feedback and develop a shared responsibility. But there are many paths to a successful antifungal stewardship, and really the best advice I can give is build on your institutional strength, and including the people that you have available. So hopefully that provides some background and basis for the next discussion that we're going to go into, talking about some of the real world experience with antifungal stewardship in the evolving healthcare landscape. Matthew?
Thank you, Professor Lewis. for your excellent presentation to share with us on how to implement antifungal stewardship in the setting. Having said that, I think it's really challenging to apply all of the 7 core principles for antifungal stewardship in a real life situation, especially in a resource limited country. So now I'm going to share with you our real world experience with antifungal stewardship in an evolving healthcare landscape. So the objective of this talk, I'm going to share with you the current epidemiology of the invasive mold disease and approach to management of fungal infections, when and what agent we should use for antifungal prophylaxis when we are going to use the preemptive strategy or diagnostic-driven antifungal treatment and the empirical treatment. And our experience with the AFS practice in the resource limited setting, and what is the common challenges in the implementing AFS in the real practice. Antifungal consumption has been increasing dramatically. This due to the enormous burden of the invasive fungal infection. Um, Candida and other yeasts can cause both the invasive and non-invasive disease, but most of the invasive fungal disease are caused by the mold infection, especially aspergillosis worldwide. As, sorry, okay. So aspergillosis and Candida, Cryptococcus, and Mucor, these are among the top the 10 most significant fungal infection worldwide and cause a lot of life-threatening infection and a very high mortality, up to 95% for aspergillosis or 90% in mucormycosis. And even though in the high-income country, the mortality of the invasive aspergillosis is more than 50%, and the estimated death was about more than 125,000 per year in non-AIDS patients. In the Asian country, this is a study from the Asia Fungal Working Group, or AFWG, to study the incident, the prevalence of the invasive mold disease in the 5 Asian countries, including Thailand, China, Taiwan, Singapore, and India. And you can see here the aspergillus are the most common invasive mold disease, followed by the mucormycosis. So to make the burden of the disease really high. This is a study in our hospital, which is the largest university hospital in Thailand. We look at the epidemiology of the invasive fungal infection in the neutropenic hematological patient, and we found the prevalence of the invasive fungal infections was about 12% overall. But in the acute leukemia patient, during induction chemotherapy, the IFI incidence as high as 20%. And the most common invasive fungal disease was aspergillosis, up to 57%, followed by the candidiasis. And these data are compatible with the study in a larger study in Italy, where the aspergillosis was about 57%, pretty much the same as our prevalence here. So this also shows that there are a significant number of the invasive aspergillosis. The host factor is important to determine what kind of fungal infection happened in the patient. Allogeneic stem cell transplantation, acute leukemia, and lung transplant recipient are among the highest risk for invasive mold infection, especially aspergillosis. However, there are novel risk factors found to be associated with this mold infection. These include the patient who receiving biological agent kinase inhibitor, particularly the Bruton tyrosine kinase inhibitor or ibrutinib, and viral pneumonia, influenza pneumonia, and COVID-19 pneumonia, as you all know. Most of the strategy for antifungal prescription are studied in neutropenic patients. But for non-neutropenic patients, we have a less data. So I'm going to show you how can we doing the antifungal stewardship in neutropenic patients. Before discussing about that, I'm going to show you the pathogenesis of invasive pulmonary aspergillosis in neutropenic patients. Once the spores of the aspergillus get into the lung and colonize in the lung, they can get infected. And if we can get the laboratory and imaging results to detect the infection, so we can start the antifungal treatment here. We can use the CT scan of the lung, culture from the respiratory system, or the blood test for galactomannan and PCR. If we can get the lung biopsy from the bronchoscopy, so we can diagnose as a definite aspergillosis. So for the antifungal strategy, we can provide the antifungal treatment here for prophylaxis before infection established, or empirical treatment before we have the laboratory results, or we can wait until we can get the lab result for preemptive treatment and or targeted treatment here. There are several studies in all these strategies using different antifungal agents for prophylaxis, empirical or preemptive treatment, or targeted treatment in the literature that you can find. This is an example for a non-neutropenic patient. This is a patient in our hospital, a 50-year-old man post-kidney transplantation, hospitalized in the hospital with a history of a fever and respiratory symptom, and the CT scan show a cavity in the lung. So without diagnostic test, so we are not going to, we are not able to allow to use the specific antifungal agent. So the physician who take care of this patient can use only amphotericin B. But in this patient, the serum galactomannan was positive, and the patient underwent transbronchial biopsy to show the invasive of the fungal hyphae into the lung tissue, and the culture from the lung aspiration grew Aspergillus fumigatus and the AFS team taken part, and then the voriconazole or isobuconazole can be used. So we require a pre-authorization for antifungal prescription. So the AFS team, including the ID physician and the pharmacist, will advise for the dose, the route, the duration, and also to checking the drug-drug interaction and monitoring of the drug level. So most of the physicians, they have fear the fear of being confronted with the invasive fungal disease that was already beyond cure obviously help to maintain a low threshold for commencement of the systemic fungal therapy in patients considered to belong to a risk group. So they tend to prescribe the antifungal agent in the high-risk patient. Some of the high-risk patients receive the empirical treatment, but we are trying to convince them that we can use either preemptive or empirical treatment. Empirical therapy is an early approach in the patient with persistently febrile neutropenia who are unresponsive to antibiotic. Preemptive or diagnostic-driven strategy is the strategy treatment usually based on the presence of the specific clinical signs and or fungal biomarker. However, there is no consensus on the definition of the preemptive strategy, and there are overlap between the empirical treatment and the directed treatment or targeted treatment. So different studies gave the different definition, but most of them are using the biomarker, for example, galactomannan to trigger the antifungal treatment, or the clinical sign or the imaging of the CT scan to trigger the treatment for preemptive treatment. So in the patient who receive the prophylaxis, they might have a lower mortality from the invasive fungal disease. However, this patient have a high exposure to antifungal agent that might have the more adverse reaction or the resistance. In contrast, if you use a targeted treatment, the patient may have a low exposure to antifungal therapy, but the mortality may be higher due to the delay of the antifungal treatment. So this is a pro and con. This study comparing the empirical treatment and the preemptive antifungal therapy in febrile neutropenic patient in a randomized controlled trial. As you can see here, that the patient who received the empirical treatment has a higher antifungal consumption compared with those within the preemptive group, as expected. So in the preemptive group can decrease the cost of antifungal therapy by 35%, but did not decrease the toxicity. And the group in the preemptive group have a higher invasive fungal disease diagnosis, but the mortality was similar between the two groups. A similar study in Singapore also compared the preemptive strategy and the empirical or fever defense strategy in febrile neutropenic patients using the serum galactomannan or GM and the CT scan to trigger the preemptive treatment. If the patient land up into the empirical arm, the patient will not test for the GM at all. So they can just prescribe the antifungal treatment if the patient did not respond to antibiotic. In the preemptive group, they perform the GM test and the CT scan. If both of them are positive, so they start the antifungal directly for the aspergillosis. By doing this, the cost of the antifungal is lower, but the more IFI in the preemptive arm, but the survival is still similar between the two groups. So both approach can be used in the institution to decide should we use empirical or diagnostic driven. There are several factors to be considered. For empirical strategy, can be implemented if the institution has no diagnostic facility available. We can use empirical treatment only to buy time until the invasive fungal disease is confirmed or excluded. If you want to use the diagnostic driven strategy, you need to have used the laboratory to screen. The screening test must be implemented in the institution and the result must be available in the same day or the next day. Of course, you must have the CT scan and bronchoscopy available. More active agent prophylaxis also important. In the patient receiving more active prophylaxis, one should keep in mind that the screening test, for example, galactomannan is not reliable. So you can rely only on the CT scan and bronchoscopy. So the factor to be considered for empirical and preemptive treatment therapy, so you should consider the risk of the patient, whether they have the high risk or the low risk for invasive fungal disease, and the availability of the investigational measure, galactomannan, beta-glucan, or CT scan institution, and the turnaround time must be very fast, within 24 hours. So the AFS is the to coordinate the intervention to monitor and direct the appropriate use of the antifungal agent in order to achieve the best clinical outcome and to minimize the selective pressure and the adverse event. So the AFS can be performed in parallel to the antimicrobial stewardship program or ASP, whereby the antifungal prescribing is optimized. So we need to know the team would know the spectrum of the activity, the PK/PD of the antifungal agent, and the suggested duration and the route of the administration. What is the difference between the antibacterial and antifungal stewardship? So for the antibacterial treatment, there's a clear relationship between the antimicrobial uses and the resistance, and the clear relationship between the clinical failure and the resistance, which is not the case for the antifungal agent. Most of the bacterial treatment focus on the empirical treatment and de-escalate later. So we call start smart, then focus. Whereas the antifungal treatment focus mainly on the targeting treatment, try to reduce the empirical treatment. So we try to make diagnosis and to identify the organism before we start the treatment. That's the most important. And most of the antifungal agent, in particular the ASO agent, require the therapeutic drug monitoring. And most of the antimicrobial stewardship focus on the antibacterial. Antifungal agents have received the less attention. So do we need the AFS? The answer is yes, because there are substantial deficiencies in antifungal prescribing behavior, and antifungal agents are pricey, and antifungal agents have the potential toxicity, especially with the long-term use and with a significant drug interaction with other agents. And there are several areas of antifungal use is inappropriate. For example, using the prophylaxis in the low-risk patient, for example, lymphoma patient, as Dr. Lewis just mentioned, use antifungal treatment to treat the fungal colonization. Treat the patient who do not have a fungal infection in a high risk because of a fear of the fungal disease, or treat the patient who are already on a broad spectrum antifungal prophylaxis. Lack of awareness of the drug-drug interaction, and have no facility to perform the therapeutic drug monitoring and use the fungal agent for too long. So this is why we need the AFS. But the problem is how to do the AFS if we don't have the diagnostic tool with the timely results. So we need to set up all these facilities in the hospital. We need the formal ongoing surveillance of the fungal epidemiology and the resistance profile. And the guideline, several guidelines available, but most of the guidelines based on low quality evidence. And the cost of the antifungal, of course, is very high. So we really need to do this. And to use the core element of the AFS, this must be tailored to the local level based on the differences between the healthcare system and practice. So we cannot do all of this at the one time, and we need to adapt to our institution. For example, this is from our institution. We need ID physician and pharmacist is at the core team of the AFS to give education and guideline implementation, DUE, and antifungal restriction, and giving reporting and feedback, monitoring drug-drug interaction, TDM de-escalation, and antifungal switching to oral form. This is what we are doing in our institution. We implement the guideline on antifungal use. The guideline must be adapted to the local context in terms of what the empirical agent to be used, susceptibility testing, set up the diagnostic test, including the CT scan, calyptomannan, fungal culture, susceptibility test, and other antibiotic control. For the hematological patient, we advise to use prophylaxis only in the high-risk patient. But though this, we do not use any prophylaxis. In the patient who have the high risk for more infection, we recommend itraconazole, prosaconazole, for example. For empirical treatment, we are allowed to use amphotericin B. And for the preemptive and targeting treatment, we are allowed to use the ASO, the more active ASO, with pre-authorization. So this is also the platform of our setting. So in our hospital, most of the antifungal agents require the pre-prescription authorization. These include the liposomal amphotericin B, itraconazole solution, and more active ASO and micafungin. So we really need the ID team 24/7 to be available. So there are the pros and cons of this restriction. The pro is that it's really highly effective to provide educational opportunity. The con is they really need a dedicated full-time personnel. And this is a potential inpatient safety due to the delay to initiation of the therapy. This is a scenario of the 30-year-old man with the AML, post-induction chemotherapy with neutropenia, without the imaging, without the lab test. So we allow to use only amphotericin B deoxycholate. One, the patient have more information of the CT scan, calyptomannan, so the invasive aspergillosis was diagnosed. So they call the team, and then we allow to use the voriconazole, isobuprofen. Another scenario is the 84-year-old man with the COVID-19 pneumonia having the swelling in the lesion at the cheek. Without any investigation, we do not allow to use any more active ASO until the patient receive the biopsy to show the blood spectrum, non-septate hyphae and grow rhizopus. So they will call the AFS team and using to use the liposomal amphotericin B and then de-escalate to isobuprofen. So in summary, the high incidence of invasive fungal diseases has a robust impact on the increased use of the antifungal agent. AFS is an essential tool to facilitate appropriate use of antifungal agents to prevent overprescription, antifungal resistance, and drug toxicity. Effective AFS requires a multidisciplinary team. This is important. And also we need the support from the senior leadership. The 7 core elements of the MS can be adapted for the AFS, but the practical AFS must be developed and implemented locally. So we have to adapt to the local context. So thank you very much.
So with that, I just want to remind you, thank you all of you for attending the today's webinar. And just one additional reminder that this is the third in this series, the fourth webinar that will be presented by Professor Monica Slavin and Tuan Mercier are going to talk about, are we maximizing the management of invasive mold disease, which will be a very interesting topic at the same time. So with that final announcement, I wish you all a good day and thank my co-presenter for an outstanding presentation.
Thank you very much.